Welcome everybody to today's webinar. This is the first plenary webinar in the Framing Rural Health Value Flex webinar conference series. And today's call topic is going to be on leadership and strategic planning. The first speaker today is Terry Hill. Terry is the Senior Advisor for Rural Health Leadership and Policy for the National Rural Health Resource Center in Duluth, Minnesota. He's also the Executive Director of Rural Health Innovations. So I'll turn it over to Terry to share his presentation.
Thank you, Leslie. And Leslie's filling in for Nicole for this session. And I want to welcome everybody to my favorite topic, which is leadership. I like strategic planning. I'm really passionate about the leadership side. And I'm going to be joined today by two outstanding leaders, folks that I've gotten to know and highly respect, and have a great deal of to share with us about both medical leadership and hospital leadership. Let me just introduce them first, and then I'm going to give a 10-15 minute presentation on kind of some of the critical success factors that we've identified under leadership and strategic planning. And then we're going to go, Kathy Johnson will follow with kind of a brief overview of her hospital, a little bit of her background. Dr. Paul Targonsky is going to follow that just basically with some of his observations on this topic as well. And so there'll be a minimum of formal presentation besides mine and a few slides by Kathy. A lot of it is going to be discussion, and we're going to build in kind of a dialogue here that we would invite you to join in on. So do feel free to share or basic questions, and we'll try to provide plenty of time, either at the end or feel free to ask them at any particular time. So today's learning objective is, first of all, to understand the need for leadership and how that's going to be important in terms of what is happening with the industry and where we are going. We are pretty strongly convinced that a systems approach or a multifaceted approach is going to be extremely important, and I think Sally and some of our speakers last week, talked a bit about this, but we want to continue to have that discussion, recognizing the need to align critical access hospital leadership boards, primary care providers, etc., around something that's going to be explainable and will be motivational to the employees. Review the use of systems-based frameworks for strategic planning to ensure a holistic approach. And then finally, understand the purpose of communicating the strategic plan organization-wide to critical access hospitals. And of course, that's something that I've observed over the 30 years or so. I mean, I don't know if I'm proud or embarrassed to admit I've been working with rural hospitals for 30 years. I've worked with well over 100. I've worked with rural hospitals in every state that has rural hospitals. And I've also been kind of coached by folks like Kathy and Paul in our annual summit meetings, where we brought in leaders in financial leadership, quality leadership, this last spring on population health leadership as well. So I'm going to start out with, again, not telling you everything, because what I've discovered working with hospitals is they can only absorb so much. They have so much to do. I try to break things down into the top 10 things that I can pass on to them, or sometimes it's the top 5. So I'm going to try to do that in terms of the learning, the lessons learned in both leadership and strategic planning based on both our experience here at the center and on the wisdom of the leaders that have participated in our summit meetings. Now, the shaky bridge, I think Sally used it in her presentation last time. We are using it as a metaphor for what is happening with the healthcare industry, and it's particularly adaptable to critical access hospitals, who are going to need to make the journey either sooner or later across a bridge, so to speak, from one payment system, from one healthcare system to the other. So again, We're currently in a pay-for-procedure, volume-based systems. We're going to be moving across into the value-based system. And even though that does not necessarily mean we're going to lose our critical access hospital funding or anything else, it's pretty clear to us and to the folks that advise us that rural hospitals and rural healthcare providers are going to either, as I said, sooner or later have to move across into that value-based future. So the cautionary point here is that while being paid in one system, we have to be careful as we're developing plans and strategies moving forward into that next system. And in essence, that's going to take even more focus on strategic planning and even more focus on leadership, because leadership is going to be the key to how many of our hospitals are able to make it across that bridge, and perhaps lack of leadership or lack of preparation and strategic planning may result in falling into the waters below. So one of the things that we've got on besides the challenges and the changes is that we have incredibly complex organizations. I like to quote Peter Drucker, who said, "Hospitals are the most complex organizations in the history of mankind." Do not underestimate the complexity and the difficulty of leading even small healthcare organizations, and consequently, leadership is going to need the kind of support that our flex programs can provide, that they can provide for themselves, and as the access to experts on the outside as well. But in our opinion, it all starts with leadership. So we've chosen in this particular series to use the Baldrige Framework here. Just prior to this particular call, we had a planning call with Baldrige organizations. And the concept here is that Baldrige is a nice tool. It's certainly been that way for a center. We would suggest it's a good tool for flex programs and hospitals to use to ensure, I mean, the center has the same concerns, has the same needs as the hospitals. We think the flex programs as well. It's about our people. It's about our leadership. It's about doing good planning. It's focusing in our customers and community, measuring our performance, and improving our processes. Whether it's a flex program, a factory, or a hospital, we feel these concepts are solid, and it's a way of kind of dividing our world. There are other frameworks out there, and I'll talk about them briefly, but this is the one that we're going to be using in our series, and we're going to hit these first two pieces, leadership and strategic planning, to begin with. So what are those top 10 things? One of them is leadership is the most important single factor in hospital excellence. It has been proven over and over again. I remember I've done a lot of research with Dr. Ira Moscovice at the University of Minnesota, and after years of research on rural health networks, we basically came to the conclusion, and I'm quoting Dr. Moscovice, the biggest single determinant of good networks from bad is the leadership. If they've got really good leaders, they tend to be really good networks. If they don't have good leadership, generally we don't see good networks out there. It may sound overly simplistic, but it's also very important, I think, in looking at future performance. In the Baldrige Framework, the leadership category is judged to be at least as important as any other category. So it gets double points, basically, moving forward. Again, we see, if you take a look at the bell-shaped curve, most of you are familiar with that, of hospital leadership, you see we have some innovators out there. We have folks really out ahead of the curve. And then we've got some hospitals that are kind of in the back end of that curve, maybe not the best leadership, maybe folks waiting to retire. Those folks are very definitely at risk, but so are the other folks that kind of the middle of that, which is generally two-thirds of the population. Our leaders that are kind of waiting to be motivated, are kind of waiting to move across that shaky bridge. And this is the group that are very much at risk and are capable, we think, of making that movement. And we're very concerned about how we help those leaders move across this gap. A second piece is, and Dr. Targonsky is going to talk about this a little bit, one of the keys to success in our blueprint in population health, and it came out of our blueprint for performance excellence as well, is that there absolutely is going to need to be a partnership between particularly our primary care providers and our hospitals. And what we know and what we've discovered in our summit meetings is that hospitals and physicians tend to look at the world very differently. Physicians are very patient-based. They tend to be a little bit less tolerant in terms of long meetings and process, et cetera. Meanwhile, communities look at the world through more of the service area. So community hospitals are much more concerned with the larger community itself and make decisions based on that. What we find, even in some of our summit meetings, is that different perspective sometimes causes misunderstandings and very often presents a gap between our physician leaders and our provider leaders and our hospital leaders. And we've got to do what we can to close that gap. And I'm going to be, Dr. Targonsky is going to be talking a little bit more about that as we move forward. But we need to acknowledge it, and for me it's one of those aha kind of things that I've learned, and just to kind of expect that we're going to see a different perspective, and somehow we've got to bring this all back around to value in population health. The third has to do with senior leadership. It really needs to be aligned, and we've done a number of performance improvement projects in the Mississippi Delta for the last 14 years. We've done performance improvement projects actually all over the country. And in many cases, what we see is a misalignment of the leadership itself. The CFO has one set of priorities. The chief of nursing may have another. The CEO has another perspective, and maybe you have an IT perspective as well. There needs to be an alignment behind the values of the organization, where it's going, et cetera. And in many cases, one of the things we discovered in the work that we've been doing is that leadership consultation on the very initial stages of performance improvement sometimes really crystallizes the issues. And in so many cases, there's an elephant in the room, which is the CEO is judged to be inflexible, or something is there that isn't being discussed. And what we found is that performance work downstream from this particular problem very often doesn't produce much impact. So access to good leadership expertise, thinking this through, and ensuring that there's strong alignment of senior leadership is extremely important. Hospital boards are really going to be a challenge here, and what we're seeing is some administrators and some hospitals just do an absolutely excellent job on preparing their board and making sure their boards are fully functional. That's probably the exception rather than the rule. We see way more instances of boards that really don't understand the changes that are taking place, many of whom might try to do more micromanagement. There's just big issues inherent in hospital board leadership. And there are tools, resources, et cetera, out there. But remember, if we have, our upstream, downstream vision of the hospital, the board is as far upstream as you're going to go. And if you get a really progressive hospital administrator in there and the board doesn't back them, they may make changes that get them fired. So that understanding is important, and we feel that this is really a key piece, and maybe something that many flex programs can hospitals on. Flex program support for leadership is crucial. And again, I don't have time to go into all of the good examples that are out there in our flex programs. Nebraska comes to mind as an early leader of, I remember years ago, Dave Palm brought his, I think it was 36 hospitals together to do balanced scorecard leadership training, and did it in cohorts over a course of 3 years, ended up training 36 hospital leaders. Nebraska also started a leadership support program, and we see a lot of examples out there in other flex programs that are too numerous to mention, of support for leadership, and we think it's going to, just given what we're talking about here, we think it's going to be an important consideration moving forward. Leadership helps to set the culture. Leadership helps to set the strategic direction, and it's also leadership's role in communicating the why, which we're going to talk about in a minute here as well. That why is extremely important, and it is one of leadership's primary responsibilities is to help to prepare a change-ready culture so that the massive amount of changes coming out are going to be effective. So in the area of strategic planning lessons learned, strategic planning needs to be made a priority. It can't sit on the shelf as so many hospitals have done. In many cases, what we're hearing is strategic planning should be done maybe even more frequently than once a year. It certainly should be checked on. It should be built into the board agendas periodically to kind of assess our progress. It has to become a priority and not something that becomes a habit and doesn't really produce a ton of value. I've seen some really excellent strategic plans, but I've also seen a whole bunch of them that are really lacking. And here's this communicate the why. This is a big thing. Cami Norland is sitting across from me, and this is part of our mantra here as we deal with communities and hospitals. This why piece is going to be instrumental about why we do electronic health records, why we're suddenly going out doing population health, why we're changing. If we're not successful in communicating that why, what we're going to find is huge resistance out there on part of providers who are very, very busy, and it's easier to do it the same old, and so it's one of the things I think that we've learned that we really value here. It's this why it really needs to be communicated, and it's a message that that can help to be communicated from the Flex program. Strategic planning lessons learned, be inclusive and partner. Partnerships is the way the industry is going. Mayo Clinic, I can just tell you, is all over the country right now. And if you take a look at Mayo Clinic's organizational chart, which I just did, I think one of the Mayo physicians shared it with me. In essence, we are seeing Mayo, which used to be pretty much a self-contained entity, forming partnerships all over the country. The merger and acquisition sort of thing we see is on a decline, and now what we're seeing is where can we put our partnerships in place? With Cleveland Clinic, for example, one of their partners is CVS Pharmacy. They instead of competing with CVS Pharmacy for minute clinics, let's partner with them. I think the same thing applies in our hospitals, and I think the same thing applies in our Flex programs as well. Let's reach out. One of the new groups that we could perhaps reach out are the state Baldrige organizations, but it includes the QIOs and everybody else that we're familiar with here. And probably everybody's seen that because I use it a lot. We're going to need those partnerships, not just to see our way through the maze, but they are going to be at the heart of the collaboratives that are being formed, the community coordination initiatives, the accountable care organizations. Oregon has already moved into an ACO-like model for all their Medicare programs for all their hospitals. And that piece is going to be very dependent on effective care coordination. And what I can tell you that working with and talking to the rural ACOs that are out there, care coordination is at the top of their list of difficulties and stumbling blocks. So this is really crucial, and it's going to require the public health talking to mental health providers, talking to long-term care providers, et cetera. Use a strategic framework. We like Baldrige. We also have about 280 rural hospitals right now are using Studer, and Studer is developing a model that is designed specifically for small rural hospitals, et cetera, and they've significantly reduced their costs. If you want more information on that, let us know. Balanced Scorecard is another really good tool, and we have tons of resources here at the center if you want more information on that. And then to begin the journey into population health and value, we don't have to cross that bridge yet, but we very definitely have to take that first step. One of my favorite philosophers is Lao Tzu, and that is, what is that first step? Maybe it's working with your public health agency. Maybe it's reaching out and doing wellness programs in your hospital, et cetera. I think that's part of it. We don't have to do it all at one time, particularly if we're already overburdened small rural hospitals, but we can, in fact, take that first step. And then the last one is really has to do with whatever we have to do. We can't just sit there. We've got to move forward, or we're going to get run over here by a train. And even if you're on the right track, Will Rogers said, you'll get run over if you just sit there. So kind of with that, I'm going to conclude my remarks and turn things over to Kathy. Kathy, if you're ready to go here. Again, Kathy is somebody that has been very gracious in coming out to our workshops in the past. She's an extraordinary leader. And Kathy, with that, I'll turn it over to you.
Thank you, Terry. Well, I live in Dawson, Minnesota, and I'm the CEO of Johnson Memorial Health Services, and it's not named after me. Everybody always has to ask that question. Dawson is 22 miles from the South Dakota border, and if you look at Minnesota, when you see that little hump on the side of it, we're right below that little hump. Dawson is only about a 1,500, a little over 1,500 population in the city itself. Our facility is a hospital district, so there are 7 townships, the city of Dawson and the city of Boyd, that are included in that district. We're a very small critical access hospital. We have run an average census between our swing beds and inpatient of 5 or 6. We have a clinic. We have 3 nurse practitioners, 1 physician, with a 2nd physician joining us now in June. We have a 56-bed licensed or a 56-bed nursing home. And then we also have an assisted living that's licensed for 16 residents. We also have ambulance service, home care, all of those various pieces. And we are very proud of our facility, and we look out here, we're one of 5 within 25 miles. So we are always comparing ourselves out on the databases for hospital compare, so on and so forth. And we really, like Terry said, you can never stop moving forward. You always have to keep moving forward, or you're moving backward. There is no holding still. We've over the last 7 years, I've been at Johnson Memorial now for a little over 7 years, and we've really come a long ways in regards to putting structure into things. I have some examples of things I want to share with you that we've put together. Terry mentioned the strategy maps, and we don't have a book of strategy. We have a strategy map. It's a single page, and we share it at quarterly at every board meeting. We share it with all the employees quarterly. It's posted in every department because these are the strategies that the board has made a decision that they want us to bring forward. We do strategic planning with a community evaluation, a survey. We've been doing it already every 3 to 4 years. Now it's mandated for every 3, which is fine. I mean, that was kind of our process anyway. But we sit down and formally go through the strategy map at least annually, and then, as I said, we review it every quarter at the board level and at the level with the employees. This is our balanced scorecard. When we have strategies, if I go back, you'll notice all these little alphabet that are on the scorecard. That connects it to our actual goals for the year. We set these up, our fiscal year is October. We set these up so people can set their goals. so that they are able to be aligned with their department goals with the facility goals. And then even further down to the employees' goals. And you'll notice here's the AAR cash on hand. Everything's not green. If it was all green or all blue, I don't think that we've done a very good job with our scorecard. They should be a stretch. And we have also found that when we put things on our scorecard, they're the things that improve. And here's an example. We've really been pushing and pushing for the optimal vascular care, which is a Minnesota mandated measure. And last year we were at 27%. And you'll see that although we're not at the state average yet, we've made a huge jump with that. So you have to know that everything shouldn't be green or blue when you're setting your goals, or you're really not stretching yourself far enough. We drive that even further down. We have our employees all evaluated, also kind of right at the end of our fiscal year. And these are, this is just the face sheet. There's a lot of data that goes in behind the actual face sheet, but this is the very first sheet of the employee's evaluation. And it talks here, we do a 1 to 5, and they might be a 3.4 or whatever on their score. But the part that I'm really interested in showing you is the part right here where it says total individual performance score. 60% of what their increase is going to be is based on their individual scores, how they do on attitude, specific things like attendance, their accuracy, how many errors are they making, how are they with teamwork, how are they doing with change, their efficiencies. 30% is on their department goals, and 10% is based off of how does the whole facility do. What did we do on the balance scorecard? And then however our budget looks, we determine, dependent on where their score is, what will their increase be. We do the same thing for managers, only for managers, they have 80% of their evaluation is based off of what are their department goals, and 20% is off the facility goals. So we really want for everybody to be engaged and to buy into what is it that we need to do to make everybody successful. Terry's got some other questions going to ask me here in a little while, and so I'm not going to present on those. But I really have to say that the alignment and the strategic planning and getting everybody involved and engaged is really key to being successful.
Thanks, Kathy, and let me ask you a follow-up question, and then I'll ask Dr. Targonsky. What would you say if you were going to list the 3 or 4 most important characteristics of an outstanding critical access hospital administrator? Let me put you on the spot here. What would those characteristics be? You've been very successful. So you can tell me from personal experience or what you aspire to, et cetera. What would those characteristics be?
Well, the things that I found that have really been helpful in being successful is, number one, being clear about what expectations are, and then hold people accountable for those expectations. But be the coach. Don't do people's jobs. Let them do their jobs, but coach them as to what it is you need from them. And then collaboration, I think, is really key too, not only with your managers, but you set that example about being collaborative with other facilities and other agencies. They'll go off of your lead.
Thanks. I've got a bunch of follow-up questions, but I'm going to turn to Dr. Paul Targonsky. And if it's okay, I'm just going to call him Paul from now on. I've known Paul for some time, and we've worked on some projects together. He's as I might have indicated, maybe I didn't. He's a primary care physician. Right now he's the Director of Clinical Research for the Department of Public Health Sciences and School of Medicine at the University of Virginia. But he previously led the Mayo Clinic Health System Practice-Based Research Network, and where I first encountered Paul. And a number of these practices were rural settings. Some of that work, and there was a project that was going on in Montana that he was involved in. And so he's worked with a lot of rural physicians. But he also was included this spring in our Population Health Summit. And he was one of two physicians that were part of that conversation. And I just found the whole dialogue absolutely fascinating in terms of the physician's perspective on physician leadership, the way the physicians kind of view the world, et cetera. So, Paul, you want to tell us a little bit about yourself? Paul doesn't have slides. We didn't ask him to do that, but just to be a part of this conversation. Paul? Start to unmute if you're on mute.
Thank you.
Yeah.
I somehow must have muted myself again in the middle of that. I apologize. Thank you very much, Terry, and thanks everyone for inviting me and participating. I actually have had maybe a number of different perspectives as a provider, having initially trained in Chicago and spent some time, working in Chicago as well as at National Institutes of Health and Centers for Disease Control. I was in public health before I actually was in medicine, and so that's actually colored my perspective in some ways as we see medicine finally coming a little bit more towards population health. I did my training at the Mayo Clinic after I had completed my MD and a PhD in epidemiology, and then I actually spent some time at Oxford in England doing work in statistical genetics and genetic epi of all things, and in a way that actually brought me very strongly back to public health, because the more I became involved in basic sciences and the more I became involved in looking at genetics, the more I realized social determinants of health are critically important and play such an incredible role in people's overall health and healthcare. And that led me back when I was at Mayo to working with the Practice-Based Research Network. And those are essentially networks that are developed to try to look, rather than at discovering new things in science, really look at the problems that healthcare and people in communities are facing on a daily basis and determine solutions using research methods so that you can get some reliable results that you can then apply not just in the community but share with other communities as well. And that seems, very relevant in, our current discussions on health reform. So most of what I was involved with was practice improvement and care coordination, looking at unique community factors, resources, rather than kind of looking at maybe what is the equivalence, looking at academic medical centers, which are kind of the equivalent of a big box department store to healthcare nowadays, trying to generalize things and understand how care collaboration and process management features can then be generalized and made replicable for other practices. So we did work throughout the Mayo healthcare system, and that was 75 practices, about 1,150 providers, and about 850,000 patients served in primary care and community-based subspecialty practices. But then we became more involved nationally in working with other providers and networks across the country, and worked in small Appalachian communities. Terry mentioned Montana. We worked in small communities in Washington and other places around the United States. And some of the issues and observations that Terry and Kathy have articulated are just spot on in terms of identifying how to make progress and how critical leadership is. So I'll stop there for a second, and maybe we can we can move to questions or
Paul, one of the questions that always comes up is physicians, particularly rural physicians, are incredibly busy. How do we get them involved in our quality improvement activities in population health, which is, they're going to have such a key role here. Can you talk a little bit about, and then I'm going to turn the question to Kathy to see what strategies have you used as a hospital administrator, Kathy, to engage your physicians. So, Paul, could you start out? What works to get, and you could throw research in here as well. How do you get docs involved in something other than that day-to-day patient care?
Yeah. You know, I think one of the things that we have to look at is how physicians are keeping busy and what, how much providers are doing or physicians are doing that may actually be work that others on a team can do. And it gets at, I think, one of the leadership issues and one of the physician training issues, which is, you know, fundamentally doctors are trained to be doctors. They're not trained to be leaders. They're not trained to be communicators. They're not trained to be administrators. They're just doctors. And so we don't necessarily always possess the skills when looking at a problem to recognize that there's alternative approaches or that there's other resources that can be brought into the equation, particularly when, you know, and I can say this as a physician, people often want to kind of take control of all aspects of care. And we've seen with the current healthcare models that really doesn't work. So we have to relieve, I think we have to relieve providers of any kind of work that isn't getting them to function at their highest level of competence, and the same exists for other health professionals as well. It does mean over time that we have to leverage technology to make our practices more effective and more efficient. But I think it also means that we have to continue to train people to be able to participate fully and comfortably in team-based care, where everyone really is acknowledged as an expert and everyone's capacity is built in that regard. And that comes back to your leadership question. And I think that, you know, there are people who are leaders by title, and then there are people who are leaders by action. And we really need to give all of our health professionals the opportunities to be leaders by action. And that means probably beginning to train people more interprofessionally and more in working within teams as a part of regular health professionals training, rather than focusing predominantly on the content that's related to a particular field, whether it be medicine or nursing or public health, for example.
Paul, just a follow-up question on that. Are you sensing that the medical schools are moving in that direction? I know I teach like a mini class in American Health Policy at the University of Minnesota Duluth Medical School, but at least in their curriculum right now, there just doesn't seem to be any space for population health or team leadership, et cetera. Do you sense an evolution on the part of the medical schools?
I do. So I think there's two questions. Is there an evolution? Yes. Are they doing it? No. Mostly no. There are nascent programs in professionalism and pilot trainings aimed at addressing teamsmanship, leadership, more interprofessional development. It's certainly not going to happen overnight. But one of the things we have to realize is that, you know, the idea as a physician as a fund of knowledge is antiquated. We have a variety of different ways of acquiring knowledge and sharing knowledge now, and the amount of knowledge that we have in medicine is no longer able to be housed in one person's brain anymore. That's not working. And so I actually there's been discussions actually at the level of medical school education to make medical school 5 years. There's actually been some discussions to make it 3 years and include additional training on professionalism and other elements as part of the post-medical school training as well. But there's an evolution there. The other thing that we're seeing is an evolving definition of professionalism in medicine that goes beyond simply being expert in your particular field as it pertains to the ability to rapidly access knowledge and make a decision based on a clinical scenario. Those ideas of professionalism are moving much more towards how is one functioning in a team environment and how is one able to be a leader in the current healthcare environment and into the future. So I think that what we'll see is, I think we will see that there will be elements of medical school curricula that will be replaced with expectations for professionalism. And over the last couple of years, I was working with Mayo Clinic when I was there, and even with the AMA on developing metrics to measure professionalism in trainees as well as in persons who are currently boarded to ensure that we have some way of building that back into continuous professional development over time. And we see that in other fields as well in health professions, absolutely.
Thanks, Paul. Kathy, give us your perception. What's been your experience working with physicians? I know you've been a director of nurses. You've had an evolution kind of up the chain. I think you started as a nursing assistant, if I'm not mistaken. Could you tell me?
That's correct. I've been a nursing assistant, an LPN, a RN, a charge nurse, director of nursing, the COO, and now I'm the CEO. So I've had a really nice career where I get to do all of those things. In regards to what Paul was just saying, I would agree 100%. We are knee-deep right now in a lean project looking at exactly what are we having our practitioners do, and are we using them at the highest level of their training, or are we having them do things that we should be having support people do? And the other thing that we're looking at in regards to the population health is Minnesota has the healthcare home, and we're also looking at, with the same project, how are we going to incorporate healthcare home and have our support people be more on top of those things. Not that the physician's not involved, certainly, but how do we divvy out that work so that they are being able to work for what they're trained for? And that has been interesting. One of the things that we struggled with out in our area is to find the clinic leadership that has the experience. And now I found that I have an RN doing that right now who is a successful leader on the hospital side. And even though she doesn't have the clinic background, she has those very important leadership skills. She listens to what the issues are. She does the problem solving, includes the physicians. They have to be a part of that, because if you're just coming to them with solutions, it's a problem. They need to be part of the brainstorming, and certainly you can throw some ideas out there, and if most of the time they like them, they'll grab them and run with them. But they have to be a part of all of those things, your planning, your all of that. But they really need to stop doing all of the things that somebody else could do.
I really like that concept of using lean then to help to kind of facilitate the evolution, because as probably most folks know, the whole concept of medical home and care coordination kind of presupposes that you've got a primary care provider that is involved in making decisions about the patient's movement through the various care levels, et cetera. So in essence, because we have a finite number of primary care providers, and as again you probably know, we're not going to increase that number significantly in the very near future, then what I hear you say is you're trying to make sure that these physicians are working at the top of their license and they're doing the stuff that they're trained to do, and those things that they're not trained to do or that they're not good at doing, you're trying to find somebody else to do it. Is that what I'm hearing?
Correct. Exactly.
You know, Paul, one of the things that I was really struck by in our conversation was, to me, one of the highlights, the most interesting parts of the conversation we had in the Population Health Summit, which is going to come out, Cami, when is that? We're looking for that in mid-June. So it'll be another one of our, it's a follow-up to our Blueprint for Excellence. It really drills down more into the population health side of it and makes suggestions of how flex programs and hospitals can focus more effectively in these areas. But it was something I already mentioned. It was we had another physician, Dr. Robert Schreiber, on our small group, and it was so obvious to me that Dr. Targonsky and Dr. Schreiber saw the world through patient care, and then we had a representative of one of the state public health departments who was adamant that it was a population sort of an approach as such, and there was just interesting, spirited conversation between the two groups. Can you talk a little bit about that, Paul? It kind of gets into that thing that you, at least in my opinion, you really have to understand the provider's perspective, and all too often hospitals either don't understand that or don't take it into account, and sometimes it's just easier sometimes doing work without physician's approval, and then what we found, or input, not necessarily approval, but what we found is that the clash comes after the physician hasn't been involved, or the clash could come because the physician's perspective is so different. So could you follow up a little bit on that as somebody who's a real expert in the topic?
So I don't know how much an expert, but it's kind of a philosophical difference, and it was made acutely aware to me, having come from a public health background first and then into medicine, that I viewed the world much more from a population level than from a patient-specific level, and having gone into epidemiology to study not just the association between exposures or risk factors and the development of a particular outcome, but kind of trying to quantify that and recognizing that there is uncertainty in those equations. It was always interesting to me to see how medical school training can often lead to a little bit more concreteness around outcomes and the weight of an individual experience influencing how one subsequently would practice, rather than the experience of populations that an individual provider may not have on their own, but would accrue from the experience of others as well. And so when I think about hospitals, and I think about physicians, and I think about, say, public health at large, a hospital almost exclusively works acutely. There is an acute or subacute or emergent event, and that event leads to an episode in the hospital. So it's episode-centered, whether it's an episode of pneumonia, an asthma exacerbation, a bowel obstruction, a broken leg, a motor vehicle crash, and those are all relatively acute. There is less of an emphasis on humans and certainly less on populations when one thinks of the general population. Maybe a population of episodes, we see more congestive heart failures than we do Wegener's granulomatosis, what have you, but it isn't that general population look. When you think about physicians tend to work, rather than acutely, a bit more longitudinally. And so working with individuals as they transition from wellness to threatened health or the development of disease and illness, sometimes back to good health, unfortunately, sometimes with worsening health, but eventually transitioning to death. So a little bit more of a longitudinal emphasis, although some acute still, but really with humans as opposed to episodes more specifically, or again, the general population. And then when you talk about public health, public health tends to work both acutely and longitudinally, but with both populations of humans as well as episodes that are affecting populations. So a much broader emphasis. And to the extent that even language, the same words can mean very different things to a physician than they can to somebody who's thinking about population, a traditional physician, as opposed to someone who's thinking population or even further along public health. So so Kathy's point is fantastic because, you know, what can happen, you don't bring, this is, you know, it's class, it doesn't matter whether it's physicians or whoever it is, you don't bring somebody in on a process and they're one of the stakeholders. You finish up a process, you hand it to them and say, look, we know you're a stakeholder, but this is how we're going to do it. What do you think? They're going to think of the exceptions. And as physicians, we're often taught to think about the exceptions. If somebody comes in with a tingly left arm, we think it might be an MI until it's proven otherwise, even though the vast majority of people with tingly left arms in the general population are not having acute heart attacks. But it's part of the training and it's part of the internal culture. So being able to shift that requires understanding where someone is from and the ability to acknowledge what it is they've been taught and they value, and to define meaning for all of the stakeholders in those processes to get to the best outcomes. And it very strongly influences discussions, in particular of process, when a process emphasis is often intended to capture some large proportion of the overall population on a population health side, but from an individual provider dealing with an individual patient side, that process is all about capturing the exceptions. It leads to two very different outcomes when you're trying to determine a best process.
Paul, that was very well said. That's been my experience as well. We just need to acknowledge that physicians are trained to think differently than most hospital leaders, and just understanding and having respect for both, both points of view, I think is going to be fundamental to making sure that we have those tight leadership alignment between the docs and the hospitals. Kathy, I noticed that you use on your balanced scorecard, you're using the Quint Studer pillars, and we just have a couple minutes, and then we have some announcements to make here. But you kind of in 2 minutes, could you talk about why that framework or frameworks in general? You've also told me that you'd like to be the first Baldrige Award winner, at the national level as well. But could you talk just briefly about why the framework has been important to you?
Well, that's part of the structure. I think that if you don't have some kind of a structure that you're going to follow, how do people know? Do they make up their own? But it's part of putting that expectation out there. And if you have some type of a structure that you're going to follow, I find that it's much easier to push that down to everybody so that everybody gets that opportunity to get engaged in that structure. And for us, we found that the pillars that Studer had really fit for us. We're not purist probably on anything because it's very dependent on our size and our culture. So we take the pieces that really work for us, but it doesn't mean that that's the only thing we do. You also heard me mention lean, and you also heard me, I haven't talked about yet, but we do Baldrige as well. And we actually are just going to be engaging and getting them out for, I wrote a grant and have them out to do a survey with us because of our structure that we use, we actually are pretty far along the Baldrige Framework. So that's really very exciting for us. But I think that all comes with that structure. People need to know. It can't be, like you talked about earlier, the alignment between not only the senior leaders, I think it's the managers, it's everybody. You need to make sure that people know what those expectations are and know the direction that you're moving, because otherwise they'll make up their own. And it's just human nature. But you need everybody aligned and moving the same direction.
And Kathy, thank you so much, and Paul, thank you as well. I'm going to, I truly appreciate the conversation. I think it's been excellent. I'm going to turn things over to Kate Stenyam of our staff to talk just very briefly about assignments and kind of next steps. But again, thank you so much for being a part of our call. And Kate, are you going to come on now?
Yep, I am. And I'm just going to go over a couple of things with Moodle really quickly. When you all registered for this webinar series, you should have received a Moodle account and access information. And so if you can all see, hopefully see my screen here, the address is just moodle.ruralcenter.org. When you put that in, it'll bring you to this page. Make sure you click on the 2014 National Flux Conference Webinar Series. And this is your login. If you can't remember your login and you know you haven't changed it, it's just your first initial and then your last name. And then your password is just password until you change it. So I'll log in here real quick and just have a couple things to go over with you guys. So here is just the overall webinar series. If you haven't actually logged into Moodle, this is what it'll look like when you log in. And the information on here, this is the overall brochure, and this is all of the information about the series. And then everything is just in chronological order by date here. So you can see there was our first webinar, and here's the webinar that we're doing today. The recording and the materials for the first webinar have already been posted on there. So what we really wanted to talk to you about was this application exercise. And this is going to be due, you can see right here, it's going to be due on Monday, June 2nd. And so don't get too nervous. It's just what you're going to be doing is reading through this case study on Community Memorial Hospital and then filling out this assignment. And what the assignment really is, it's just a way for you to get to think about some different things on how you would apply this case study. And then we really want it to use it to encourage dialogue on our cohort discussions. So all you have to do to open either of these is just click on them, and they're going to download. And once you have your assignment finished, it'll probably take most of you, I bet, 5 or 10 minutes to do it. Once you have your assignment finished, you'll go into this, and you'll hit Submit Assignment. So you just have to click on that. And then this will come up, and as you can see, nothing is going to be graded. And you go down here, and then you hit Add Submission. And then you can either add it this way by clicking on here and then going in and, if you saved it on your desktop, your assignment or whatever on your desktop or one of your folders, you just hit Choose File and then upload it onto there. Or you can easily, too, if it's on your desktop, you can just drag it and drop it right in here. And then when you have it in there, all you do is hit Save Changes, and it'll automatically be uploaded. And don't worry about you don't have to have your name or anything on the assignment because it's actually associated with your user name that you log in with. So we'll be able to see, who belongs to which assignment. So yeah, we just wanted to quickly walk you guys through that. It's really easy, but if you do have any questions or you get in here and you get confused, make sure just to give us a call and we can help walk you through it. So with that, I think that's all that we have for Moodle today. If you haven't actually registered for the webinar series, make sure that you do that, and then we'll be sure to get you your Moodle login information as well. And again, that first assignment you can see on here is due on June 2nd. And that is it from my end, Terry.
Thanks, Kate. And that's all we have for you today. Just to note again, the first assignment is due Monday, June 2nd at 5 p.m. And if you have any questions, contact us And also the first